From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome to our listeners around the world. This is Dr. Eve Rittenberg, and you're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. Today we're talking about preventing sexually transmitted infections with Doxycycline Postexposure Prophylaxis, or DoxyPEP for short. DoxyPEP aims to prevent chlamydia, gonorrhea, and syphilis with a single dose of the antibiotic after condomless sex. And this strategy has been shown to be effective in randomized controlled trials, but the study we'll discuss today helps us know what we really care about, which is what it looks like in real-world practice. So I'm looking forward to talking with our guests today. Dr. Stephanie Cohen is the senior author of a study that examined DoxyPEP and sexually transmitted infection trends in San Francisco. She's the director of HIV and STI Prevention and Control at the San Francisco Department of Public Health. Welcome, Dr. Cohen.
Thanks. It's a pleasure to be here.
And I'm also really thrilled to have Dr. Preeti Malani join us. Dr. Malani is deputy editor at JAMA and professor of medicine at the University of Michigan and a specialist in infectious disease. So welcome, Dr. Malani.
Thanks. It's great to be here.
So Stephanie, I wonder if you could give us just a little bit of context of sort of what you noticed in your work at San Francisco that sort of drew you to this topic and what made you interested in looking at DoxyPEP.
So I'm an infectious disease trained physician and have been working in the field of HIV and STI prevention for about 15 years. And when I started at San Francisco Department of Public Health, it was just a few years before emtricitabine tenofovir, or Truvada, became FDA approved as an HIV pre-exposure prophylaxis method. And I've spent much of my career focused on how we can optimize the rollout of HIV PrEP so that it reduces HIV rates and reduces disparities. And it's been such an exciting field to be a part of because, as you probably know, HIV PrEP has really revolutionized the field of HIV. And since rolling out HIV PrEP in San Francisco, we've seen steady declines in HIV rates. On the other hand, over my career, we've been experiencing very rapid rises in bacterial STIs like gonorrhea, chlamydia, and syphilis. And so many of us in the field have been interested in whether this biomedical prevention concept that's been so successful in preventing HIV infections could play a role in bacterial STI prevention and control. So that's how I first entered this space of starting from the clinical trial context, efficacy studies, does DoxyPEP work, to actually thinking about how do we implement it and how can we measure its impact at the population level.
It's really interesting to think about expanding on those successes in the HIV prevention world and thinking about it in a broader range of STIs. And can I ask, as you did this, as you entered into this next step, what did you find when you started looking at the population level? How does this work?
I think it's important to note that San Francisco was one of the two cities that participated in the randomized control trial of DoxyPEP that was done in the United States. And that trial, as you mentioned, showed that DoxyPEP can reduce the incidence of gonorrhea, chlamydia, and syphilis in men who have sex with men and trans women. So because we had participated in the RCT, we were very well suited to be at the kind of cutting edge and leading edge of implementation of this intervention because we had a lot of awareness and interest in our community because folks had been hearing about the RCT and some of our community members had participated in it. So we in San Francisco convened experts and stakeholders after those RCT results came out to start immediately talking about whether and how we would roll DoxyPEP out in San Francisco. And with that, in October 2022, we became the first health department in the country to issue guidelines for DoxyPEP use. So as an early adopter city, we really also felt that we had a responsibility and an opportunity to start to take a look at the million-dollar question, which was, could this really make a difference on a population level? And that's what we sought out to do in this study.
Yeah, so tell us. So what did you find?
So what we did was we did an ecologic analysis to look at STI case counts in San Francisco in MSM, men who have sex with men, and trans women prior to the release of our DoxyPEP guidelines, and then in a period of time after the DoxyPEP guidelines. And we did this using a modeling method called interrupted time series analysis, which allowed us to model out and predict what our case counts would have looked like if the trends in STI rates had stayed the same, and compared those modeled estimates to what actually happened in the months following the release of our DoxyPEP guidelines. And what we found was, in fact, there was a significant decrease in both chlamydia and early syphilis in men who have sex with men and trans women following the release of our DoxyPEP guidelines. And we did not see the same decline in gonorrhea infections.
So let's hold that for 1 second, because I thought it's interesting to think about what that differential finding might mean for the difference between real world and RCT results. But I want to turn to our other guests. So Preeti, could I ask you just to tell us a little bit about why you think the study that was done is so important, and what should we think about the association of this decrease in chlamydia and early syphilis due to DoxyPEP? What does that mean for practicing clinicians?
Yeah, thank you, Eve. This is really compelling and important work. And just stepping back, I know Stephanie and her colleagues presented this work last year at the CROI meeting, the Conference on Retroviruses and Opportunistic Infections. This is the major clinical conference on HIV. And that was really a topic of great interest for people attending. As an editor, I also got excited about it, and I was really hoping that we could recruit this work to be somewhere in the JAMA network, and I'm delighted that it's going to be published in JAMA Internal Medicine, really because this is not an infectious disease specific topic. It needs to be more in the general medicine space. And so I'm hoping we reach a lot of readers with this work. You have the randomized trial, which shows that this works, and you know that this works. The real world is not a randomized trial. And we also think of it at the individual level. And people, perhaps their partners could benefit. But what is so compelling about this work is that you really have done in a robust, very rigorous way, shown decreases in a population of San Francisco. Now, is San Francisco like the rest of the world? Perhaps not. But this is also a model for other people to do similar work and to see where the gaps are, because there are concerns with this intervention around resistance. Adherence is something that is really important. It came out in the randomized trials, and it's, again, something to think about and ways to increase adherence. And also from a sort of higher level clinical vantage point, as people engage in care to receive DoxyPEP, they, of course, should receive other kinds of care too. And not just in the STI arena, but really care more generally. And so I think that this is really important, and I applaud the work that Stephanie and her colleagues have done.
Yeah, thank you so much. To me, as a primary care internist, this felt incredibly relevant as you think about, sort of all the work that we do is in mitigating risk and shared decision-making about strategies for staying healthy. And this sort of felt like it falls clearly into that realm. I wonder, Stephanie, if you have thoughts about the ways that your results were similar to or different from the randomized controlled trial results, and some of the reasons that you might have seen those differences.
Yeah, so I think the results were different and not different in a couple of notable ways. So Preeti alluded to the fact that adherence was important in the randomized controlled trials. And I want to come back to that point because our study focused on bacterial STIs in men who have sex with men and trans women, which were the populations included in two of the large randomized controlled trials, the US-based study called the DoxyPEP study and a French study called DoxyVac. There was a third, also very important DoxyPEP RCT that studied cisgender women in Kenya. That's called the DPEP study. And in the DPEP study, doxypep was not shown to be efficacious in preventing STIs in cisgender women. And in that study, it seemed like that was largely driven by low adherence. When looking at drug levels in the participants in that study, not very many were actually taking the doxypep. In our study, we did also look at citywide chlamydia rates in cisgender women, and we did not see any change in chlamydia in cis women in San Francisco after the release of our doxypep guidelines. Now, we're not recommending doxypep for cis women in San Francisco because we don't have that RCT evidence to support it. But I think it's important to note that without RCT evidence for the intervention, and then without recommending it for a population and supporting its rollout and uptake, we're not going to be able to impact trends in that way. So that's a similarity that we found. A difference was in regards to gonorrhea. So in the two RCTs I just mentioned, the doxypep study and the doxyvax study, the participants who were randomized to doxypep did have a decreased incidence of gonorrhea. Now, the decrease in risk for gonorrhea in the RCTs was not as significant as it was for chlamydia and syphilis. In the RCTs, doxypep reduced the risk of chlamydia and syphilis by about 80%, versus for gonorrhea, it was about 30 to 50%.
Let me just stop and interject that I just want to reinforce those are huge differences. I mean, huge.
Very profound decrease.
Yeah. I mean, even the gonorrhea one that's so much lower is still, yeah.
It was still statistically significant, and it would be a clinically significant decrease if those findings had held true. But what we found in our study was that citywide gonorrhea case counts in men who have sex with men and trans women did not decline after the release of doxypep guidelines. So that's an area that we're still investigating and trying to understand why at the population level did doxypep not seem to have an impact on gonorrhea. And I think there's a number of different reasons that could explain it. The most likely one, though, is that the gonorrhea strains in San Francisco and circulating nationally may be resistant to the tetracycline class of antibiotics that doxycycline is in. And that's something that already was known about gonorrhea before all of this work on doxypep began.
Great, thank you. So the last question that I have for you both, it's sort of drawing on what you just told us about the existing data that we have, but I'm wondering what both of you think are the next steps in this field, both research-wise or clinically. What do you want to see happen next?
I think there's so much work ahead of us in this field. It's very exciting to finally have an effective tool to prevent bacterial STIs. And now there's a million more questions to answer. So I can't understate the importance of having a prevention tool for all populations in all gender categories, including cisgender women, as well as more research that's inclusive of transgender and non-binary populations. There are some additional RCTs underway that will be enrolling cisgender women, and we're staying tuned for those results. There's also interest in looking at different dosing regimens. So this particular intervention, as Preeti mentioned, is taking 200 milligrams of doxycycline after condomless sex. There are some investigators who are looking at daily doxycycline as pre-exposure prophylaxis. So there's a lot of interest in both all populations as well as different dosing strategies. And then there's a whole world of implementation science to understand how do we support interest in this intervention? How do we train providers to include it as part of a comprehensive package of sexual health services? What are the potential risks of doxypep? We need to make sure we're monitoring as we scale this up resistance, not just in gonorrhea, but also in other bacteria like staph and strep. So there's a lot more work to do to understand how to most effectively, safely, efficiently, with an equity-focused approach, get this tool out to our communities.
I might just add to that, I hope other cities, other localities will consider this, not just in the United States, but other parts of the world. So we have more experience understanding what's happening at the population level. Of course, we need to keep our eye on resistance. And as Stephanie mentioned, not just on the particular STI pathogens, but things like strep and staph, since doxycycline is used clinically in those spaces. And then really understanding the issues around adherence. And if I think about PrEP for HIV and the fact that for years we talked about, well, it just doesn't work as well in women. And it turned out it really had to do with adherence. And it may be the same case here. And so I think the more we can really understand this so that we can offer prevention to a wider number of individuals. And I'm pleased that there are ongoing studies in cisgender women, and as well as all the other studies going on with dosing and timing of treatment. And all of this is probably temporarily going to be helpful. The bugs always win. We say that in infectious disease, the bacteria will always win. And ultimately, we also need to keep working on things like a vaccine so that down the line, the way we prevent particularly gonorrhea is going to need to be different.
Thank you both so much. I just learned an enormous amount, and I'm left really excited thinking about the future of this field and how much there is left to be learned and implemented. So I'm just grateful for both of you for being here. I'm Dr. Eve Rittenberg. I've been speaking with Dr. Stephanie Cohen and Dr. Preeti Malani about DoxyPEP to reduce the risk of sexually transmitted infections. You can find a link to the articles we discussed in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. And thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.